Hi everyone, I'm Shelley Bolliton. I am a member of the Centre for Vaccine Preventable Diseases. I'm an associate professor at the University of Toronto and I'm a scientist at Public Health Ontario. I'm really pleased to welcome you today to this webinar on community outreach and engagement during the COVID-19 Vaccine Rollout. The seminar is being hosted by the Centre for Vaccine Preventable Diseases at the Dalla School of Public Health, University of Toronto. So before we start the webinar today, I want to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. Today, this meeting place is still home to many Indigenous people from across Turtle Island, and we are grateful to have the opportunity to work on this land. So just before we kick off, I have a couple of housekeeping items. After the panelists speak, we're going to address as many questions as we possibly can. If you do have a question, you can put it in the Q&A chat box that is at the bottom of your screen. If you have questions afterwards, you can direct them to the following email address, cvpd.dlsph@utoronto.ca. So I'm going to start by introducing our three panelists today. So our first panelist or speaker is Sophia Ikora. Sophia is a health policy professional with nearly 2 decades of experience in health system strategy and over 10 years of experience in executive roles in healthcare. She is the executive director of the Health Common Solutions Lab, which is a health policy innovation lab, which she launched in 2017. Here she leads a multidisciplinary team and designs and tests practical solutions to some of healthcare's most complex challenges. Sophia has held senior executive roles inside and outside government, in local health planning authorities, and also served as an advisor to 3 health ministers and the Premier of Ontario. Our second speaker is Nicole Blackman. Dr. Blackman is an Anishinaabe German Kwe, or woman, and a proud member of the Algonquin of Pikwanigan First Nation. She has worked as a registered nurse since 2004, when she began her career as a floor nurse on the medical radiation unit and chemotherapy clinic at Princess Margaret Hospital. Upon graduating from the nursing diploma program, Nicole earned a Bachelor of Science in Nursing through Ryerson University, as well as a Master's of Nursing through the University of Toronto. She also has a doctorate in nursing practice through Walden University, with a post-secondary academic focus on Indigenous health practices. Nicole has dedicated her advanced practice nursing career towards implementing a model of holistic health and well-being and supporting Indigenous health and Indigenous hands. She's had the opportunity to serve as Director of Professional Practice for a First Nation governed health authority in the James and Hudson Bay region of Northeastern Ontario, as well as the Health Director for Mississaugas of Scugog Island First Nation. So unfortunately, Nicole is going to be departing the webinar after her talk, but if you have any questions, you can use the email address and we will direct them to her. Our third speaker is Frances Garway. Frances is a systems leader with expertise in the healthcare sector, leading strategic clinical expansion and integration and system design. He is a builder of medical interprofessional teams and sustainable partnerships, and a leader in strategic change enablement and integration. He has successfully led the development of an integrated full clinical service delivery model throughout the Durham region urban catchment service areas, and multifaceted partnership agreements with universities and several community service organizations with the objective of providing seamless services for patients and clients across sectors. Outside his role as Chief Executive Officer, he also has extensive boardroom experience, having served on several public and not-for-profit organizations. He currently is on the Board of Governors for Ontario Tech University and the Zimcan Health Board. He's a recipient of the Honorary Ambassador Award from Dallas Baptist University in 2002 and 2006, and the United States Achievement Award for Outstanding Academic Achievement from the United States Achievement Academy. He's also held positions as the VIP Protocol Advisor for the 2015 Prince George Canada Winter Games and was a torchbearer for the 2010 Olympics. He has a master's in organizational management with specialization in healthcare management and a Bachelor of Science, both from Dallas Baptist. He is a ProSci certified practitioner in change management, certified coaching out of the box practitioner, and a dedicated leader committing to empowering organizations, teams, and communities to achieve their fullest potential. So with that, we're going to kick off with our first speaker, who is Sophia.
Thanks, Shelley. It's a real pleasure to be here today. So I'm just going to share my slides. I'm pleased to be able to kick off the panel presentations this morning, just talking about very broadly the opportunity that comes from co-designing with communities and the transformative power of communities improving the health of the people that live there. So I just want to talk quickly about what we have learned, some of the things that actually we were reminded of during the pandemic, 3 key lessons that I think the system needs to be paying attention to. The first is something we've known for some time, but it's an important reminder that health is the product of social, historical, and contextual factors. So we have known for a long time that the social determinants that drive health include income, housing, food security, racism, and opportunity. And they not only shape health, but they also determine things like access to healthcare services. These things combined tell us that health and the determination of health is very much a local process. The second is that health outcomes are unequal. And this was very clear during the pandemic, the patterns of variable outcomes can be seen clearly across geographies and also across distinct groups. And then the third is that I think the systems that produce these inequities cannot be relied upon to have the solutions. So we know that communities are experts in understanding what they need to address the gaps that are left by overlapping system failures. And these things in combination really point us in the direction of knowing when we need to turn to communities to have different outcomes. This graph was posted in the Toronto Star very early in the pandemic, but I think it's one of the clearest pictures of how differentially impacted different groups were. It's a picture of the rates of COVID spread across Toronto. And what you see along the bottom is on the day that we began to lock down, so all non-essential workers remained home while other essential workers had to go to work. What we saw was almost a perfect split. So those who could remain home, the highest income earners and the least racialized ended up seeing that flattening of the curve that we talked about, and the most racialized and lowest income neighborhoods that had to continue to go into work, travel on transit every day, many of whom live in denser housing conditions and multi-generational homes. We saw in those populations that classic sort of big curve spike over the preceding months. So this picture really illustrates for us just, I think, the shape of the curves and the very different experiences. I want to talk a little bit about a case study that Health Commons Solutions Lab was able to sort of be a part of, and this is a case study about the high priority community strategy. So this is a strategy that was funded by the province in January 2020. And it was in recognition of the experience across 16 communities, those who are both most highly racialized, lowest income, but also had the highest rates of COVID. And that's how they were selected by those combination of factors. You can see they cluster around the GTA, but they also stretch down into Windsor and also up into Ottawa. Our experience with them started when we approached the Rexdale Community Health Centre and the North Etobicoke planning table that was hosted by United Way in the City of Toronto. And through our series of conversations, including about 120 interviews with community members and leaders in the community, what we learned about was how the pandemic was really exposing those structural factors that marginalized many residents in these communities. And it was a combination of things like housing insecurity and job insecurity, food insecurity, lack of appropriate transportation, dense housing conditions. All of these factors came together to shape the experience of community members at the time. But we also learned through those interviews from community leaders where there were opportunities to change the trajectory. So there was indeed sort of a lack of testing in these neighborhoods, which largely sort of fall across the borders or the edges of downtown Toronto. Whereas the testing really was in the middle corridor and quite far away from where people were contracting COVID and where they were living. So access to testing was really critical. But we also learned that The public health messaging really wasn't working effectively in these communities. Things like social distancing, staying home were really not options available to members in these communities. And so that created a gap between the legitimacy of the public messages and what people were hearing. There was a lot of misinformation. But there was also an opportunity to leverage natural communications channels. So people who were trusted community leaders who could carry messages and do the education and outreach with the legitimacy that's required to reach people in meaningful ways. But I think the third and most important thing that we heard was that in order for people to be able to get tested and feel like it was safe for them to get tested, we needed to address the stigma around that, but we also needed to make it possible from an income, food security, and housing security perspective. So people were making a rational choice not to take a two bus ride trip downtown to get tested if it meant they had to stay home and wouldn't be able to make rent or put food on the table. And so wrap around community care that really addressed the whole person, the whole household, that was a critical element of making it possible for people to be able to get tested and to stay home and protect their household and their community. So these are really critical insights that we would not have, I think, come up with if we hadn't spoken at length with community members and with community leaders. And just to give you a sense or a flavor of the impact of those consultations, the community design of this intervention, and then the subsequent funding of those 16 lead agencies. Within the first 12 weeks, so from January 1st, when the announcement came out, to the end of March, what we saw was the mobilization of over 700 partner organizations, the hiring over 1,300 community ambassadors. They were trained and already out on the ground, standing up of 37 testing sites in these communities, and over 1 million tests that were completed during that period of time that had not been previously happening. So you can see the numbers really show a very dramatic picture of a quick response, pivoting as required, based on the community expertise. And it really did make all the difference in these neighborhoods. And Francis can speak to this thing more directly because he was one of our lead agencies. Just a couple notes about what I would say was important about this initiative. One was that there was really nothing new that the community sector was doing differently. They've always known how to respond to the complexity of experiences around health. What was different in this instance was that government took a much more entrepreneurial view. So they named lead agencies, they provided a lot of flexibility around funding, and they turned over the trust and the power to communities to really plan for themselves. And it made a very significant difference. So I'm just going to quickly sort of summarize what we see are the opportunities for imagining a future state of working with communities much more effectively. There's sort of 4 key areas. One is to first really try and understand the picture, not from the perspective of those who sort of work at Queen's Park or people who are traditionally in planning roles, but to turn to community and use a combination of data and also qualitative information. The second is pivoting in real time to respond to information as it's coming in. So at the beginning of the pandemic, WhatsApp was the most effective way to reach people. And we've seen that there's been a change in which channels work when, and really only the community can tell us that. The second and probably most important is really shifting the balance of power. So as consistently as possible, we need to hand over the microphone to community leadership and allow them to speak on behalf of their communities and what they understand. We really need to give them both trust and also the resources to be able to move quickly and not have to sort of check in constantly around the design, but to do what they know best. Doing this does a couple of things. When you uncover a whole new set of experts around the experience and also what's shaping health, but also you have community members that are willing to lean into the problem because they are naturally and intrinsically invested in the health of them, their families, and the communities that surround them. So you get a whole new set of assets. And I think finally, just continuously working in a highly networked fashion, really local, really networked across health and social partners, community leaders. These are the patterns that we saw emerge from the communities that worked tremendously hard and yielded huge benefit. So with that, I'm going to turn it over to Nicole.
Good evening, everyone. Thank you for joining today's webinar. To the host, thank you for having me. I am here to briefly discuss outreach and engagement from an Indigenous perspective. Next slide. When we look at COVID-19 and what's taken place, the lower vaccination rates in the Indigenous population and so forth, it's important to understand the hesitation Indigenous peoples may hold and to appreciate that the history of pandemics experienced by the population is a long and oftentimes dark one. From the time Europeans arrived on Turtle Island, or what is now known as North America, to the present COVID-19 pandemic, Indigenous peoples have in many cases been disproportionately impacted by infectious diseases. It's widely documented that the arrival of Europeans to Turtle Island brought a number of diseases to which Indigenous peoples had never been exposed, such as smallpox, measles, and yellow fever. And because Indigenous people didn't have the antibodies necessary to prevent infection, they experienced depopulation as more and more communities came into contact with European ships and explorers. Next slide. In some cases, Indigenous people were subject to intentional genocide by European settlers, with the most well-known incident of intentional infection occurring in 1763 during the Pontiac's War. And this is where the British, under the military lead of Geoffrey Amherst, used blankets exposed to smallpox as germ warfare in an attempt to subdue the First Nations resistance to unlawful land acquisition. Smallpox was lethal to many Indigenous communities, seeing sweeping epidemics repeatedly affecting the same communities, wiping many out completely. Next slide. The disproportionate effects of disease on Indigenous communities or peoples continue to be a factor well into the 20th century, with Indigenous communities being hit hard by the 1918 influenza pandemic. And a primal lesson that was learned during the Spanish flu was an inequity shaped who lived, who died, and what the future lives of survivors would be like. Deaths among Indigenous peoples were higher than the non-Indigenous. While 6.2 out of every 1,000 non-Indigenous Canadians died of influenza, mortality rates among the Indigenous population ranged from 10.3 per 1,000 cases in PEI to 61 deaths per 1,000 cases in Alberta. And many of these cases, these deaths were preventable. The impacts of poor housing, for example, was well known before the pandemic, but public investment was lacking. Health advice for hygiene and self-isolation was impossible to follow in overcrowded, poorly ventilated houses with no hot running water. And this is a situation that is still very much a reality for many First Nation communities across the country today. Next slide. For Canada as a whole, the history of H1N1 is seen as a success story. The epidemic was not nearly as severe as was initially feared. There were fewer hospitalizations and fewer deaths in many regions for H1N1 than during a regular flu season. But this was not the case for Indigenous peoples. In 2009, Indigenous peoples made up roughly 4% of the Canadian population, but they accounted for 26% of those who became critically ill. First Nation leaders made many requests and waited over a month for the delivery of gloves, masks, and hand sanitizers. And as communities waited for the much needed shipments of PPE, public health officials spent several weeks debating whether or not to send hand sanitizers over concern that the alcohol content might be abused by individuals. After waiting nearly a month for the delivery of PPE, First Nation leaders were shocked to find dozens of body bags crammed into the shipments of supplies. Even worse, many of the shipments did not contain the protective measures that were promised, such as the hand sanitizers and antiviral treatments. When Health Canada announced vaccine rollout guidelines in the fall of 2009, Indigenous peoples were initially excluded from receiving priority access. And this did not sit well for many First Nation leaders who emphasized that Indigenous peoples had been disproportionately impacted by the H1N1 virus. Next slide. Systemic equities placed many Indigenous communities at risk to COVID right from the beginning. And it is because of these inequities and discrimination in the health system that has caused Indigenous peoples to suffer disproportionately from the virus. Federal and provincial governments have urged hand washing and social distancing as the best defense against the virus since March 2020. But many Indigenous communities lack access to clean water, and inadequate housing has led to severe overcrowding, making social distancing difficult. In urban settings, Indigenous peoples are also overrepresented in populations at heightened risk of COVID, such as those experiencing homelessness, those in correctional and congregate settings, as well as those living in poverty. And to make matters worse, Indigenous people in Canada also have higher rates of the underlying health conditions that place them at greater risk of severe complications from COVID, such as diabetes, TB, or heart disease. Next slide. Unfortunately, this pandemic has brought out the worst in people, and the previous subtle anti-Indigenous racism all of a sudden exploded. First Nation leaders who attempted to protect their communities to the best of their ability through lockdown restrictions were met with resistance and anger from locals who didn't want to lose access to their lower cost cigarettes and gas. Indigenous communities were told that if the locals couldn't go into their communities, then they couldn't come into theirs, and it blocked access to essentials such as food and medical services. Next slide. Unfortunately, when it was announced who was prioritized for phase 1 of the provincial vaccination rollout plan, there was not a clear communication as to why the Indigenous population was included, along with long-term care residents, those 80+, and healthcare workers. And as a result, this did two things. For the Indigenous population, it created further mistrust, as many didn't understand why they were going first, and questioned whether it was that they were guinea pigs again, like they were as children in residential schools when they were tested on with the TB vaccine. And for many non-Indigenous, it sparked outrage and viewpoints that Indigenous peoples were jumping the queue and being freeloaders. Indigenous organizations and individuals experienced racism when offering and accessing vaccination appointments. Even myself, when getting my vaccine, I reinforced my prioritization by stating my position as a registered nurse because of the negative reaction that I received when I had the Indigenous box checked. Next slide. When looking at community outreach and engagement in the COVID-19 vaccine rollout from an Indigenous perspective, it's important to understand and appreciate that pandemics past and present for Indigenous peoples greatly impacts the decisions made on how and who information will be heard from and treatment will be received from, whether the treatment is preventative or curative. It has been heard loud and clear that Indigenous people want to hear from Indigenous experts. And this speaks to the importance of Indigenous health in Indigenous hands as an essential strategy to address medical mistrust and vaccine hesitancy. Partnering with local Indigenous organizations will create equitable access to culturally safe services and increase the likelihood of Indigenous peoples vaccinating themselves and their families. Next slide. An approach to consider when collaborating with Indigenous communities on vaccine rollout is two-eyed seeing. It speaks directly to the setting of collaborative cross-cultural work, intentionally seeking to avoid the situation of clashing between knowledges. Rather, two-eyed seeing embraces learning to see from one eye with the strengths of Indigenous knowledges and ways of knowing, and from the other eye with the strength of mainstream knowledges and ways of knowing, and to use both these eyes together for the benefit of all. Next slide. To support this approach to equitable access to vaccination, IPHCC strongly suggests that anyone working to vaccinate the Indigenous population complete a 30 to 40-minute online module that outlines the strategies to support Indigenous participation in Ontario's COVID-19 response, which includes engagement, partnership, and leveraging existing trusted relationships. Next slide. For additional learnings on how to work in a culturally safe way, IPHCC has recently released the first course within the Anishinaabe-Minowayan approach to Indigenous cultural safety. The foundations of Indigenous cultural safety is important for anyone working within the health system to take. So Chigmigwich, thank you very much for your ongoing support and commitment to equitable access to vaccination that is inclusive of Indigenous peoples.
Good afternoon. My name is Francis Garway, CEO for Carea Community Health Centre. Thank you very much, Nicole and Sophie, for setting the context. Hopefully I'm able to project here. You can see what I have here. So just following up on what has been shared with this rich information regarding the history of why this initiative has been successful. And the context that I'm going to be sharing with you here is where does the success lie from the community outreach engagement specific to COVID-19 in the rollout in the community. So a number of sections that I'm going to walk you through to give you the context as well is the appreciation of lead agencies in the environment in which they operate and the environment in which they've already created some of their pre-existing relationships. Thanks to Sophie for pointing out most of these methodologies are not new to what you understand the communities to be. Of crucial importance is understanding that the work that was done was to enable the idea of making sure that integrated primary care and social supports and community connections are part of the key anchors and the pillar of making a one-stop shop possible to be able to reach and contact and inform as well the communities that we are seeking to achieve some of the outcomes on. A couple of things that I will mention here, which were shared by Sophie and also Nicole earlier on, is that opportunity to make sure that community partnerships in co-creation, co-design are part of the key ingredients of the success. The context I'm giving you is coming from Durham. There's about 16 of these lead agencies across the province. So the Durham context was quite widespread. As you can see, the partnership that falls under the umbrella deliberately to making sure that these connections and these partnerships are already partnerships that existed before COVID, but they are also partnerships that come in with rich trust and also partnership that comes with lots of cultural and knowledge that is required to be able to bridge the gaps that are required in these communities. So a couple of things that will actually be coming to you not as a surprise in terms of what exists in that current state of engaging the community with wraparound supports. When you look back from what exactly were some of those inequities that existed, what exactly are some of the challenges that these communities have been experiencing? Remember, we are talking about communities that has already been marginalized, communities that are already been facing multiple barriers. Those barriers are some of the challenges that either made their situation worse, if they were not bridged. So here's a couple of them that I'm going to make sure I highlight on. Education and health teaching in terms of what exactly is involved in the work that we are doing in terms of educating on testing, educating on vaccination, but also those health teachings. Why were they important, mostly in those hotspots, the communities that we're working with? So remember the first word that we used at the beginning, trust. So the trust that was built were built through the work that we're doing with the ambassadors and we continue to do today. So that work includes these ambassadors coming in from directly the communities in which they are giving the services. Our hiring, our engagement was very deliberate to ensure that the efforts that we're trying to reach can be tailored to the language that the community is familiar with, to the relationship that they have with the leadership in the community, clergy. It could be sometimes counselors, it could be also uncles and aunties who are within those spaces. So the key elements, especially in the education, we focused on teaching on nutrition, but we also focused that teaching on digital literacy, in also connecting some of those inequities on digital literacy with the private partnerships that we were bringing in from private organizations who would actually donate some of the services to come in to build that net or nest of supports that gives these communities the supports that they need. Sophie earlier on, indicated in her presentation that, remember what made it work is the ability for the government in announcing this initiative, the ability to be flexible around the edges to give the lead agencies and the communities the ability to understand that one shoe size does not fit all. How do we customize those approaches to make sure that when we are dealing with case management, it's specific to those individuals that need certain supports, to make sure that the work goes on uninterrupted. The key ingredients of some of this work, even as we saw it in creating these as health hubs, we're focused on a number of areas. So when you begin to think about the work on testing was happening in kind of multiple areas. So key pieces that you would be able to reflect on are going to be based on what is the difference when you are testing in neighborhoods of low priority communities, multicultural communities. What is it that was needed? For us, the approach was to be able to kind of build the ambassadors through the communities in which, when we brought them in, we were giving an opportunity for those ambassadors to be informed specifically by the leaders in those communities. Some of these meetings that were happening would happen in non-traditional hours. You know, let's talk about evenings, after work. How do you make sure that those environments, you know, could allow that? But also within that hub, majority of the people, when they show up, sometimes there's a lot of indecision that's in there. Again, because of sometimes the gap in the information that's available. How do you make sure that information can be, you know, shared in a way that is not threatening, that is not intrusive? The idea was not to convince people, but to share information in a way that allows decision making from a place that comes from trust, and also making sure that the critical information that makes an individual reach a decision was given in a language that allows them to understand and be even to take that information back home, sit on it and vet it through. You will hear more about the languages when we come. I'll give you some opportunity to ask questions later on where we can share. We had over 5 different languages in which we translated the information across the region so that the communities that we were serving are able to take that information and digest it in languages that they understand. But also for some of those families who are struggling with, say, digital literacy, that information was actually packaged and also supported with a warm handoff to make sure that at least they understand what it means. How do I book my COVID test? And even if those digital inequities exist, how did we make our ambassadors be part of those families so that they can walk with them hand in glove up until the point that they can make a decision to get the best outcomes that they are looking forward to. So I'm going to pause here, wait for the opportunity for some questions where we can give you more information regarding what are some of the skills that we have seen work and what we hope to see going forward as the future of COVID seems to be with us for a long future to come. Thank you.
Thank you very much to all 3 speakers. Those were really fascinating, really informative talks. So while we wait for the participants to ask questions, I'm going to kick us off with a couple of questions. So the first one is both to Sophia and to Francis. Clearly, these are success stories. What do you think prevents governments and policymakers from doing what you describe on a regular basis? So from consulting and co-designing interventions with communities on a regular basis. Francis, maybe you want to start us off?
Sure. The notion that it costs too much when you give communities the flexibility to be able to co-design or create in a way that addresses the community gaps is actually a misnomer. The reality of what we learned and experienced through this situation, there was a lot of volunteerism in which knowledge resides in those communities. They came in with some of the out-of-the-box solutions that did not cost any money, but the opportunity that was there was to understand the application of the cultural nuances. You were hearing earlier when Nicole was speaking about there's a historic context behind some of the hesitance that we've learned through vaccinations, but also that historical context was the appearance that the government sometimes, if they don't have enough information, there could be misinformation in there. So what was mostly important was the ability to be able to demonstrate through bringing people to let them design what works for them. Our job within that space was to hold the pieces together as we continue to drive the agendas forward.
Thank you. Sophia?
Yeah, I agree wholeheartedly with what Francis is saying. I think there's a lot of fear that drives I think the lack of consultation. To be honest, I think there is fear around what happens if we I think there's a desire to control the factors that government's willing to take on, right? So if you broaden the field and you ask questions like, what are all the factors that are really contributing to this health challenge or this outcome? There's a sense that it might get out of your control, and you may be asked for things that you can't necessarily produce. I think it really represents this failure to understand that there are real cohorts and populations that experience health quite differently, and it is a combination of the health and social factors and the social determinants of health that drive that. So if you try and control very tightly the questions you're going to ask and fields of interest that you have around what the intervention might include, you're going to leave some of the critical aspects of it out. So it leads to a failure in being able to close that gap. So I think that that's one thing. I think also, and we're starting to overcome this a little bit, but there is this persistent idea that equal is equitable, and we know that that's not true. So until very recently, we thought about whole populations and sort of one size fits all. And increasingly, I think with more conversations around population health approaches, we are beginning to understand that there's real utility in breaking down the experiences and the way that our systems are accessed by different subpopulations. So we're starting to have, I think, these building blocks, willing to consider a broader range of factors, willing to think about different kinds of solutions, and hopefully that's going to drive us to asking the right people questions about what would make a difference.
Thank you. Thank you for that answer. The next question is also for both speakers, and it's about evaluation and lessons learned. So maybe we'll start with Sophia. What did the Health Commons Solution Lab learn when you did an evaluation of the high priority communities work?
You know, I think, and I talked about it a little bit in the presentation, I think the first piece, and Francis also talked about this, is that many of the solutions and strategies that work in areas where there's real complexity of the problem, right? So we're not just talking about a healthcare access issue, we're talking about all the factors that shape it. In those instances, the people who best understand what it means to sit in the middle of a bunch of system failures are community leaders. And they'll also help you, community members and community leaders will also help you prioritize, like what's most important and what would make the biggest difference. So where the system typically goes is to the places where they have the most amount of control. We need to get as many people tested as possible, as many tests as possible at once. And so, you know, we opened up testing centers in the most obvious places from that perspective, hospitals that could crank volume. But the reality was, you know, when we were first working in North Etobicoke and Rexdale, the closest testing center was 2 bus rides away, and it was a drive-through. So in North Etobicoke, where many people don't have cars, they were truly excluded from access. So it didn't matter how many tests were happening at that site, they weren't testing the right people. So I think really going to community and asking them what are the material differences, but where you put the service, what hours, who needs to staff it, who should be there to support people's decision making. That was really critical, and communities really know how to do that well. And so I think the first piece was we need to turn to where the expertise is. The second is that because this problem was rapidly changing, there was a real need for flexibility that the systems typically don't have, right? It's very hard to turn a big ship. But if you turn over, I think, responsibility, power, and resources to those who can work very nimbly and very quickly, alongside some real clear accountabilities, simple accountabilities, how many tests, how many points of contact, how many vaccines, you allow communities to do what they're going to do best. So I think that there was this, the big evaluation finding for us was how useful it is when we as governments and system planners become much more entrepreneurial, really ride like where the most momentum is. I think those are the major findings. And then I think, and we're very happy to share this, the specifics of what communities do is helpful. So really understanding what does it look like when an organization like Francis goes out to understand people's experience in the community. How do they do that? The focus groups, the conversations, relying on their existing channels, and the specific tactics and techniques that they use. Those are all sort of revealed through the evaluation, so they can be shared really broadly. And as one community figures out what's happening well, it's important to share it across as many as possible.
And thanks, Sophie, for that. So I'll add a couple of things there that are, you know, quite incredible, which is what we learned also through some of the surveys that we have put through as we were running through some of the testing centers. Folks needs consistency. The communities, if you are not going to be consistent, they are fed up of, again, this ability that things will come because of the flavor of the moment and they will go away. So remember, trust building is a huge investment in anything you do through population health lens, and to be able to build sustainability and consistency. That was crucial for the work that we are doing today and that we started doing from the early stages of phase 2 of the COVID, wave 2 of the COVID. So a couple of things that I'll give you as an example. In the beginning, we were chasing some results based on FSAs, that is the high rate of positivities within, the West Durham. And when we do those tests, you do it, in one spot, tomorrow morning you drive, you go to another spot. So people will show up for those little quick to-do pieces. But when we just gave them a little bit of a survey and understanding what exactly would make you come with your family, because we wanted to make sure that it is a family event. And they have actually asked for that, to say, make it a family event, then we can trust that. We started to build these permanent hubs within these FSAs, where they now know they could come, not just for testing, not just for vaccination, but now they can come to get their blood pressure checked. They can now come also for their nutrition, also education given. But also these other conversations regarding my husband who is, or my wife who is, or my partner who is the only sole breadwinner. They have actually been on quarantine for the last 2.5 weeks. I am not sure I can be able to pay my electric bill. I can't afford the grocery bills. So that opportunity in those secret surveys that we were giving, as we were giving these clinics in these neighborhoods, allowed us to, for those two things to happen. Make sure you are consistent in the space that you are. We are really invested in meaningful relationship, not to see you once and you disappear. Lesson number 1. And actually we learned this, if you recall, even if I paraphrase the words of the former late President Mandela, he said, the best way to get to a human heart is to speak with them through their language and the culture they understand. You'll be definitely guaranteed that the message gets through to where it needs to be. So that happened, which was really crucial. So, and I'll summarize the next piece was also the ability to be able to involve other, organizations like, think about churches, clergies. When you bring them in, there's a lot of resident knowledge that is not found in any book, because that trust comes through their religion, in terms of what is it that they need to be able to make sure that it's at the forefront to build those trusts. So it allows even the notion of us building these permanent sites was actually information that was coming from those communities to say, do this. So they became the vehicles of success towards some of the early wins that we see. And the work is not done, especially through these, which we call wellness hubs. We are actually learning even more as of today to say, this should be the way how primary care is given. I need it when I need it, where it's close to me, and anytime that I'm able to get to it, so that I don't have to face barriers of transportation, and also barriers that they face that include, things like accessibility and sometimes the lack of health cards, which we've heard about during that time, which caused a lot of maybe the low uptake, because people were feeling, maybe I'll be asked a health card, I don't have one. So we were able to comb through that noise to make sure that we get to the forefront of the real challenges through their participation.
Thank you for both those answers. They're really informative. There's a related audience question about evaluation, wondering whether there is a report available for either of the work that you have done on the community ambassador program, so lessons learned, recommendations, because it would be useful for advocating for this type of program in other jurisdictions. So either of you who wants to go first and comment.
Yes,
I'll say yes, and Sophie, I'll let you speak. Definitely, we do have a lot of information that has been collected, and the Health Commons Lab has been quite, at the forefront of all of us actually supporting the work that's happening at best practice. And I'll let Sophie speak in terms of the availability and the ability to share that kind of report.
Yes, for sure. So I've just actually dropped into the chat the evaluation that we have. It's very detailed. Like I'm also trying to find the shorter version of it. This is an evaluation of the standing up the high priority community strategy across all 16 of the lead agencies. It sort of provides examples from each of the lead agencies of how they went deep on some of those areas around, seeking first to understand, working with a network of partners, activating community leaders and community ambassadors. There's also some very specific information there from the community ambassador work. And there is a community of practice that is run every Tuesday with about 70 or 80 community ambassadors it's a small cohort of the many that have already been hired. They're trained through those conversations, but they also really share strategies with each other around what works. And so if people are interested in joining that or having their community ambassadors or outreach workers join that community practice every week, there are experts that come and speak. They get to talk to each other. Please reach out and we'll connect you.
Amazing, thank you. Our next question from the audience is whether our speakers think that messages about COVID vaccinations have been too loud and drowned out other healthcare messages. Have you found evidence that fewer people have sought out care for other health needs? So maybe Sophia, we'll start with you.
I don't have the answer to that question. I think what we have seen is a lot of people who have delayed care. But that may not be just a function of messages about COVID vaccination, and it may be just challenges in getting access to care. What I will say is that I think that what happens right now during our response is going to make or break our trust relationships between people and systems going forward. And so if people feel coerced or negatively impacted, or they have bad experiences, they experience discrimination, during this time, it really does have a negative and long-reaching sort of implication for people's trust in systems. And Nicole spoke to this very eloquently when she talked about successive breaches of trust between governments and Indigenous communities. And so I think it is really critical to think about what we're doing in our relationships and why it is important for those who speak on behalf of the healthcare system with communities, are from community and are part of community and really intrinsically understand them. I'm not sure whether or not the reason why we're seeing delayed care is specifically because of the communication around COVID vaccines, but I do know that the vaccination programs are putting some strain on people's sense of trust in the systems, which is why it's critically important communities lead, particularly in this moment.
Thank you for that. Francis?
Thank you, Sophie. Along those sides, one of the messages that we have heard constantly is that, don't forget that I'm not defined by my disease. I'm not defined by the vaccine. I'm defined as a human being with multiple other needs. Those conversations were very loud and clear even as we interact with people. Hence, when you heard me speak about the wellness hub models that you saw us actually creating and building through this time of the pandemic, were specifically to say, yes, we understand the message about COVID is out there. The message about testing is out there. We are encouraging people to be tested. But we can talk about these other holistic ways of trying to support you, despite just the aspect of testing and vaccination. So we saw that actually build a large momentum for some of the people who were actually quite challenged to come in just for the conversations for COVID vaccinations. So it allowed them to be able to be checked in for these other pieces like diabetes, other issues like nutrition, COPD, stuff like that. So that opportunity to be able now to bring that approach as a wellness hub, it allowed them to even get other care. Just to the question that was posed by the previous audience to say, did this really impact? I would say actually it even helped open up other avenues and the conversations that were not initially covered at the beginning of campaigning for testing and vaccinations.
Thank you. For the next question, can each of you share examples of what community leaders are? So we heard a lot about the engagement of community leaders and how important that is. Who are the community leaders that you have engaged with?
So Sophie, I can start here. We are in Durham, which is a wide region that, as you know, with multiple households. The key aspect that you have to understand when we talk about community leaders, think of it from politicians, think of it from local organizations. As an example, Black Chambers of Commerce. You think about Indigenous family, cycles. You also think about other cycles such as the youth leagues. There's different leadership in most of these, communities that actually have a captive audience to the communities that have membership into some of those cycles, where folks always gravitate towards for things like guidance, be it spiritual guidance, be it, maybe employment guidance, where they've always gravitated towards. So those leaders through those organizations were the folks that we engaged to make sure that they can give us the appropriate avenues to engage. Even when you heard me earlier speak about translating into multiple languages to make sure that the message reached the audience, it was based on this community leadership, like the Tamil Association of Durham, the Black Health Alliance, it could be other organizations like the Chamber of Commerce, like I spoke to, the newcomer societies, within, Durham, and you find this right across the GTA. So those community leaders are actually who became the first conversation, openers, who actually would, mentor and also open the doors for the ambassadors to be able to engage within those spaces.
Yeah, I think that I agree with Francis. I mean, I think the only thing that I would add is that if you're not sure who the community leaders are, you can just ask, right? Like, I think what surprised us was where people were getting their information from, and actually the opportunity that was there to sort of tap into it, right? So if you ask people when you're asking them also, like, what's been their experience and what makes a difference for them, who do they go to for information? Where do they go for information? You'll get a line into what the opportunities look like. In some cases, it's the Somali Women's Association, which was traditionally a place where people would go for food baskets and, for information when they first had their children. That became a really vital source of getting information out to the Somali community in North Etobicoke. And so it's going to be a surprise sometimes for you. Definitely, there are opportunities to engage faith-based leadership across a range of communities and populations in neighborhoods. So I think when we don't know, we just ask, who do you turn to for information and advice? And those are often the formal and the informal leaders.
Thank you for that. I think we have time for a couple more questions. Given that most of these activities took place during lockdown, one attendee is curious to know what challenges you experienced trying to engage with communities while not being able to meet in person. Did you find that you were able to effectively communicate to community members digitally or by telephone?
So consider this to be, and we are learning this as we go, what we consider to be a hybrid model. And that hybrid model, again, gets informed by some of those inequities that we spoke about earlier. In other places, we found in-person was more appropriate, specifically in some of these congregated settings in which not everybody is going to have internet bandwidth to sign in and be able to be online. So you'd use the in-person interaction. Remember our key message, hiring from those communities in which we are trying to serve. Those ambassadors are more in tune to what works best within those communities. And then within the pandemic, with the lockdowns, definitely at the beginning, the challenge was getting out there, knocking on the doors. Remember the rule from day one, before even the vaccines were available, was, making sure that we do, we did observe, some of the conversations regarding maintaining that 6 feet to make sure that people were able to get the information that they need just in time. But the provision of PPEs allowed some of those in-person services to be given in such a way that allowed them to hear, the information in a timely manner. So that was there. And even right now, as we go forward, there are a couple of thoughts that we continue to work with in terms of engaging to say, now that we are where we are, what could make it work for you? Remember, we don't want to build it and hope that they'll come. We want to be able to get them to let us know, yes, maybe technology was working yesterday. Maybe I don't need it today. So we tend to, kind of make it so flexible that we kind of go back and forth where it's needed, because that one size fits all is not going to work if we build it that way. So this also informs the success of this initiative as we go forward to say, I think even in our reporting, there is a statistical information that's going to be, shared based on what we digitally collected, but there's also narratives that we are collecting through these some anecdotes, information that gets shared within these community consultations that are happening either virtually, and some are in person for those small group settings based on the restrictions that are available at that moment.
Francis, I have nothing to add. That was great.
I think we have time for one more question if we answer it quickly, but I think it's a really insightful and important question. How necessary is it to also not only engage residents and communities, but also frontline workers within health to inform future best practices?
So I think that, this has been a really humbling moment for our healthcare system and also for healthcare workers. I think it's been really difficult to show up to work every day, and also to expect to have the answers to all of the questions and all the different permutations. And so I think that there's two parts to it. I think there's ways of really working with frontline workers to support them in letting them know that they're not alone, right? They're not alone in trying to find answers to these sometimes very challenging questions of how to penetrate into communities that they were never successful with before. That you have a much bigger set of assets that we can leverage, and that we can go deeper and be more effective with the community as a partner. And so I think that sense of success that will come from partnering is something that really nurtures and cares for the workers who are at the front line every day, seeing the negative implications. And so I think often when you see fatigue among healthcare workers, it comes in part because of this sense of being overwhelmed and not being able to make a difference. I think really sharing how this has been a successful strategy and has critically required both frontline healthcare workers, our traditional system partners, and community partners, and that it's really made a difference, I think is important. And I think the humility of being able to say, in most instances with a complex problem where everything's shifting, we don't have the answers, we can't be expected to have the answers, but we should know how to ask. And so I think that would make a big difference in helping take some pressure off of the shoulders of the healthcare workers, but critically important to support them as well.
Yeah. Thank you very much.
And Sophie, I'll close and add that to say, we as healthcare workers, we are designing a system that we also use. And in that, we are the people that needs to be able to learn on what works for our clients or patients, works also for us. We are the provider today and the patient tomorrow. So if that could be really a key anchoring message that actually speaks to how important it is for that information to be shared, I would say that would be the most crucial message to take away from that.
Thank you very much. I think that those are great concluding remarks for today. I want to thank our panelists and our audience for joining us today. And we will see you next time. Take care.